pancreas. And pancreas is, a major organ responsible for producing insulin, right? And insulin is necessary for the body to utilize glucose. So it's all about, carbohydrates. You know about all the different food groups. But carbohydrates in particular, the end product when we eat, right? It starts from the mouth, it gets broken down into pieces, digestion takes place as it passes through the GI tract, right? So the end product is glucose. So each time we eat, piece of bread, potato, what else? Pasta, right? It gets, rice, different things that we eat. It gets broken down, and the last, the end product of it is glucose. And that's the only way the body can absorb that food we ate. That's the only way. So, but for the body to utilize glucose, right? Glucose gives us what? Energy. It's the energy that we need. So, but the body can't just, it goes into the, into the bloodstream, right? So when we eat, it goes into the bloodstream, and this glucose will be floating in the bloodstream, right? It will be circulating through our body. So then, but the energy derived from glucose can only be useful to our muscles only if we're able to have the glucose get into the muscle cells, the cells of the body. So it has to be able to have access to the cells of the body, so the cells of the muscle tissues. So that's what insulin does. So the only way the body can utilize it is by it binding with glucose, and that's the only way it can get into the cells. It cannot get into the cells by itself. So that's why when we have problems, in people who have diabetes, we're talking about inadequate amount of insulin or the body not being sensitive, So the pancreas has to be working well. So these are the main things with diabetes, right? So it's glucose intolerance. So we have too much in our bloodstream, and the body is not tolerating the amount. It's causing problems. We have too much. So either there's problem with production of insulin, release of insulin from the pancreas, either there's a problem with it, or the pancreas is actually producing insulin, may actually have so much insulin that it is producing, but you know what? They're not sensitive. The insulin is not sensitive to that, oh, I have too much glucose, I need to, take care of this glucose so that and have them go into the cells. So those are the problems that you can identify. So people who have diabetes, they have different things going on, right? It may be somebody whose pancreas is no longer producing insulin, so that's their own problem. But it may be somebody whose pancreas is actually producing, but it's not sensitive. All right, so the main thing is, if somebody has diabetes, we want to go to the bottom of it to know what's your main issue. You understand? So we can have two people who have diabetes, but the reason why they have diabetes is because of different things, right? So maybe somebody who's, sometimes as we grow older, things actually change, and we have autoimmune problems, rheumatoid arthritis, right? People with autoimmune problems. The thing with autoimmune problem is that the body now develops antibodies, right? We start having autoimmune problems. What are other autoimmune conditions apart from arthritis, rheumatoid arthritis? What are that?
Sjogren's.
Huh?
Sjogren's. Sjogren's.
Sjogren's?
Yes.
It's lupus, yes.
Lots of hormones.
It's several, yes. So, and the body will not develop antibodies. The antibodies can now start destroying insulin or make it not sensitive, or start destroying different organs, start causing problems. All right, so the whole thing is, if somebody has diabetes, what's the main problem with their pancreas or their own body system, what's going on, right? So look at diabetes now. It's not that somebody, we go in a room with our patients who have diabetes. It's not the same thing that is their problem, right? So that's one way you have to look at it. So there's alteration in carbohydrate metabolism, alteration in fat metabolism and protein metabolism. Okay, and then another main thing to understand about diabetes, because we have so much glucose and we have impaired glucose use, right? It causes problems. So it causes complications. And these complications are long-lived complications. They're really, from the time somebody gets diagnosed as having diabetes, many times they've had it for like months before they actually figure it out. Okay, so there are different ways. One, we're going to talk about the two types, right? But when we talk about like the type 2, like some of us, we don't have diabetes, but as we grow older, things change. And people develop diabetes as they grow older. That's the more reason why they won't even know unless somebody who's really involved in taking care of themselves, and you need your annual physical and you go to the doctor and the doctor will draw blood work, right? And just check and they find out, oh, your glucose is really high. Okay. Or somebody who's really, somebody who may be having symptoms. And they say, I've been, things have been different. I've been feeling differently lately, then that's why I came, all right, to be safe. So, like I said, the insulin has to be sensitive to the glucose and be able to drive it into the cells. So that's what you see in this picture where you have the normal person. The normal patient has good functioning pancreas. So this pancreas has some insulin. So the normal person has no problem. So actually, the way it works, it's homeostasis. Homeostasis is actually the way it gets balanced before the problems set in. So homeostasis, negative feedback mechanism, positive feedback mechanism. So when we eat, through the process of homeostasis, through the process of negative feedback mechanism, when we eat, we produce glucose, right? So the body, through the communication patterns, it gets that information that now, I've eaten, now I have glucose, therefore I'm going to stimulate the pancreas to produce insulin, and it should produce insulin to take care of the whatever amount of glucose we have circulating in our system. So that's normal for a normal person. The pancreas is responsive to the glucose in our circulation. So it produces just a good amount of insulin to take care of it. So this person will not be having excess amount of glucose in their bloodstream, right? But when we have problems, when there's, with the problem of diabetes, there's a problem with homeostasis. The balance is off. So that's the reason why we will have, somebody will have pancreas that is producing insulin, but this insulin is not sensitive because that mechanism is not working anymore, right? It's not working anymore. Or that they have, but it's not enough. So normally, negative feedback mechanism is when I have insufficient amount of insulin to address the glucose that I have, therefore my pancreas should know to produce. So that's the negative feedback mechanism. When it's not balanced, we need to balance it by this producing, stimulating this. It's a whole bunch of process, going through the hypothalamus and all those and stimulating this to produce insulin. All right. So this is a type 1 patient who is diagnosed as a type 1 diabetic patient. So the pancreas does not produce any at all. So it is very important for you to understand that, have that in the back of your mind, that a type 1 patient who is diagnosed as having type 1 diabetes, they have pancreas that does not produce any, no insulin. All right? The type 1 person, no insulin. So you see the pancreas of this person, the type 1 here, there's no insulin. The lights show insulin, right? So they're not producing any. So the important thing for you to understand about this, because their pancreas is unable to produce any insulin, that individual then must, remember we said the only way the body will utilize the glucose will be using insulin, right? Now, this person has pancreas, but the pancreas is not producing it, all right? So this person must get insulin, must. There's no choice about it. They have no choice, right? They must have insulin, and that insulin, because the pancreas is not producing, must be external source. They must go shopping for insulin. Just take it like that. I thought about it this morning. I said that's like going shopping. They have to go shopping for insulin. Yes. If they sit there, they're done, right? We need energy. All right, so think about the type 1 person has to go shopping for insulin. Now, so that's what you see here, because that's the only way that they can utilize glucose, right? So those people that we have to give a shot of insulin, so we go shopping, we bring the insulin, we inject that insulin. They must have it. So remember many years ago, yes, Dave?
I'm confused.
Okay.
Okay, I know like the type 2 you get the shot.
We didn't get to type 2.
We didn't,
That's why I want you to get this before we talk about type 2.
Type 1, don't you just take a pill?
Okay, so listen, you need to listen very well. Type 1, we're only doing type 1 so far.
Yeah, but don't you just
No, listen, I'm going back.
Okay.
I'm going to say it again. I want you to get it as we go along, all right? So we already talked about the normal person, right? You see this picture, right? You have it on your paper?
Yes.
Okay, so this person is a normal person. When you look at the pancreas here, the lines, it means insulin.
Yeah.
It means that person's pancreas is producing insulin, right? And the explanation I gave to you here is that the body needs insulin to utilize the glucose. That's it, right? If you get that part, right? We must have insulin somehow for the glucose to be driven into the cells, the muscle cells. We need it. Now, type 1 person, right? They have this pancreas. Look at the picture. If you have it in your paper, the pancreas has no insulin, so you don't see those lines, right? So it doesn't. It's devoid of insulin. Whatever is going on with the type 1, something is wrong with the pancreas. That you know what produces insulin in the pancreas? They are the beta cells. The beta cells within the pancreas are the ones that produce insulin, right? If you ever remember your anatomy and physiology, it says the islets of Langerhans. That's where the beta cells are, and that's what produces insulin. So the type 1 person may have problem with those cells. You know, something may have destroyed it. It may be genetically, induced. It may be autoimmune, right? Or maybe different things, right? But just know, think about the pancreas as a factory. It's a factory producing insulin. And now this factory closed up. Insulin will not come anymore, right? That's it. The type 1 person's factory closed up. Doesn't produce any. They gotta go shopping. That's what we're saying. So you get it. That's it. Just to start with that. Type 1 person must go get the insulin. And depends on it. If they don't get it, something will be wrong. They will suffer the symptoms, they will suffer. Now, so I said they must have it, right? And there's something else I wanted to say, but I'll get to it. Okay, so their the glucose will be high in their bloodstream. It will be high, it will stay high. Each time we do finger stick, because we're checking their blood, we will get high numbers. We'll get high numbers for them. So they have to have that insulin. So we give them a shot of insulin. Now, The other factor about it is this. That type 1 person, remember I'm saying the body, we need energy, don't we?
Yes.
That's the only way. If we have no energy, we can't function. We're so tired, right? So the type 1 person, before we go to type 2, that type 1 person, the body says now, I am starved. My cells are starved of glucose. The cells are starved. They starve because there's no insulin from their pancreas, right? Their cells starve. The cells, they have no energy. So, there's what's called compensatory mechanism. Right? The body has a way to, okay, this is happening now, therefore I need to do this to compensate for this lack of insulin, right? So the body then goes to break down the fat stores, right? So within our body, right, we have fat tissues and stuff, right? So this is important for a type 1 person. So before we give the insulin, if we have not, they're taking too long, right? Was taking too long to get to the shop to get the insulin. So the body starts breaking down the fat to get the energy. You see why? If you think about the picture, just visualize the picture of a type 1 person. They're usually thin because the body breaks down their fat. So that's the typical you see. It doesn't mean that you don't get somebody who is, maybe a little bit off, the typical. So a type 1 person is usually a thin person. Many years ago, that's the thing I wanted to say. They used to be called, instead of type 1 diabetes, they used to call them insulin dependent because they depend on it. Insulin dependent diabetes mellitus. So they don't use that term anymore, but they prefer to use type 1 and type 1. And knowing that there are several, little variations. All right? So you get that for a type 1 person. Their factory closed, it's not producing insulin, they must go and get insulin. They depend on it, we must give it to them for them to be okay. Right? We get that, and they're usually thin because the body breaks down the fat, so they're usually thin. So that's a characteristic of a type 1 person, right? Now, the picture here shows type 2, and the type 2 person has its pancreas that is producing just scant amount. It's producing some. So their cells will not be starved like the person in type 1, right? Their cells will not be starved of glucose because the type 1 person will break down fat. But the type 2 person has some insulin. So some glucose gets into the cells. So the cells will not get to the point of starvation, right? So that's why when we talk about a type 2 person, we know that their pancreas is there and it's working, but maybe not efficient, not working to the full capacity. So when we talk about type 2 in terms of treatment, they will now go and look at the pancreas or what the underlying problem is, and they make pills to meet up with whatever their specific needs are. So if it is that the pancreas is not producing enough, some of the pills that the type 2 people, only type 2 gets pill, only type 2. So the pills that they get, sometimes it is just to stimulate the pancreas to produce more. All right, so that's one way, some of the pills. But if it's only for the person whose pancreas can be stimulated to produce more. So they get that pill.
What's the name of the pill?
Huh?
What's the name of that?
Oh, we're going to talk about it. We're getting it little by little. Just know that, we're really not talking about that, but it's, it's important to say it because that's what differentiates the type 1 from the type 2. Yes?
So if they don't take the pill, they will have the same complications like type 1. Right?
Okay, good. So, because they have some insulin, not enough, they still have glucose in their bloodstream, right? It's the same thing. They eat, type 1 person eats, type 2 person eats, they get end product glucose. Now, the type 1 will have some insulin, some of this glucose will go into the cell for a type 1, type 2. But the type 1 person will be waiting until we give that outside source, right? Meanwhile, it will be taking care of itself by breaking down the fat. Say, I know who I'm gonna get. I'm gonna go to the fat. I'm gonna get my energy from the fat, right? And we'll do that. But so now the other part, when they do this, that's a major thing that differentiates a type 1 from a type 2. Because of this, they produce ketones. All right, so that's what differentiates the type 1 person from a type 2. So this is type 1 person, right? Type 1. So you need to understand this and remember it. Because the body starts breaking down the fats because the cells are starved, right? Starvation. So the problem, complication associated with the breakdown of the fat is that they produce ketones. Ketones are acidic. And when you think about somebody in type 1, they have metabolic acidosis, metabolism, related to metabolism of fat, metabolic acidosis. So the ketones are not good, right? They're not normal. We don't want to have ketones, but that's what problem they suffer from. Yes, Jima.
I got to the part of type 2, they have a fact that they produce insulin, but not enough.
Yes.
So do they also get a starve?
Their cells will not starve like the type 1 person.
Okay.
But I'll tell you where they starve. The type 2 person, we said, so they are less likely to depend on the fat breakdown, right? The type 2 person, less likely to depend on that. But do you know when their cells will suffer? When somebody is fasting, a type 2 person starts fasting, right? Because then there's no glucose, right? They didn't eat. So it gets a little tricky. Don't worry about that. We'll get to it towards the end. But to start with, the primary problem for type 1 is that they have no insulin. They must get it. The primary problem for a type 2, they have some, not sufficient. Okay. And remember, we're saying it's a matter of looking at the pancreas or looking at their individual system. What are the problems? Now, it may be they not start thinking about the way to address this problem. So sometimes the pills, I said, it's maybe to stimulate the pancreas to produce more, maybe to stimulate the liver. All right, because liver has storage of excess glucose in the form of glucagon, right? They convert the excess glucose into glucagon, and the liver stores it. When the cells are starved, the liver can release some of that. But remember, we're not talking about normal. We're talking about disorders. So the variety of disorders. So this diabetic patient, maybe somebody who's having problem with their liver. And so remember I told you homeostasis, negative feedback mechanism. The feedback works. Okay, it's cyclical, it just has to go. It's like a loop that has to take place. But things start changing. So this is the feedback. If let's say the liver, the pancreas, the brain, because it's the hypothalamus, right? The GI system, all these things, right? There is communication, the feedback. But it's a little bit more complicated, different things that's going on. So they need to find out what's the problem with this person. Is it the liver? People may have cancer of the liver. And the liver starts producing abnormal cells. When there is cancer or tumor, sometimes they produce abnormal cells that can mimic the normal ones, and it can stimulate the liver to release all the glucagon they have. So the glucagon, when it's released, it's more glucose inside the bloodstream, right? So it may be a pill. They may now make a pill to stop that. So some of the pills diabetics take, they have specific effect based on the specific individual. So when you have two people, they may not have the same problem. So you wonder, why is this person getting, example of the pills, Prandin, and this person is getting glucophage? They have specific effect on that diabetic patient, whatever their problem is. All right. So the negative feedback mechanism, when it fails, different things happen. All right. So the type 2 person has some. So their cells are not usually starved. They are less likely to break down fat. They are not prone to ketones. It's very important to differentiate those things. This is the same thing as the first picture, because it just shows how the insulin binds to the glucose and drive it into the cell. This is a normal person. They have some glucose here because they have insulin and no problem. They're not starved. This is a type 1 person. You have all the glucose molecules on the other side of the cell, within the bloodstream. The cells of the body cannot utilize it because we are not seeing the insulin. See the insulin, or it could be somebody who's not sensitive. The body is not sensitive, so we have some insulin and it's not sensitive to the glucose, so it doesn't bind together. And this is a type 2 person, has some, and so the cells will not starve of glucose, but we just need to boost it. All right. So statistics: over 20 million people in the US have diabetes. And the worst thing, over 6 million do not even know that they have it. Remember what I was saying? Because people develop it maybe after a while, and because you've never had diabetes, so you're not checking those things until you start feeling some of the symptoms that the diabetics feel. Symptoms of dry mouth, symptoms of having to pee so much, right? Different symptoms, blurred vision. The glucose does damage. Starts doing damage. Once you start having an extended period of time with so much amount of glucose in your bloodstream, not know what to do with it. So normally we need like 70 to 120, the blood sugar. That's how much glucose we need on a normal person. Diabetic patient has greater than 126. So sometimes 300, 400, 500. So these people, we're saying over 6 million people are unaware that they have it. These are some of the people who all of a sudden they start becoming very blurry, the vision is blurry. They go to the I can't see well. I don't know what's going on. Or I couldn't sleep last night. I was in the bathroom so many times. And when they check their sugar, they find out it may be 600. Some people have been 1,000. Yes. People walk around with that, not knowing. But the worst thing, this complication, it starts happening from the time our body starts having so much, level of glucose. It starts damaging the blood vessels. That's why you see at the end, several people who have diabetes, they end up with amputations. Because it's not something that just happened overnight. It's something that happened over their lifetime, from the time their pancreas starts acting up. All right, so it's so expensive to maintain it, right? Remember, they have to go shopping. All the people who have type 1 must go shopping. It's so much. And then, because of the complications that happen to them, they're in the hospital all the time. So it's so expensive, over 132 billion a year to treat diabetes, right? So same thing we talked about so much. Insulin-dependent diabetes mellitus, that's what it used to be called. They also used to call it juvenile diabetes. Now they prefer type 1, right? Type 1. So majority of the cases are more type 2. So it's like only 5 to 10% cases are the type 1 cases. So not so much, right? There is some genetic component, right? So genetics. When it's in the family, if your mother had it, father had it, so grandfather is more likely to also have such, right? Autoimmune, remember I said the autoimmune could be autoimmune induced, when we develop antibodies because of the autoimmune problems. Destruction of beta cells, anything that causes destruction of beta cells, whether it's cancer anywhere, cancer of the lungs can spread to every other part and spread to the pancreas. Cancer of the colon can spread everywhere, right? Anything that destroys the beta cells, and so the beta cells can no longer produce the insulin. So we said their pancreas does not produce any, right? And it's common in the young people, and they're thin, usually thin. They are prone to ketosis, so you gotta remember that. Prone to ketosis when they break down the fat, all right? And the type 2 person, but 90% of the cases are type 2. 90% of diabetic cases are. There's also genetic component, so that's similar to type 1. There's a genetic component to it. Now, they have some insulin, so the beta cells are producing some, not enough, right? So it may be that, remember I said that feedback mechanism must be working. If it's not working, that means when the body will not sense that it has too much glucose. So the beta cells are not being responsive by producing enough, adequate amount. So maybe the problem that they have. Tissue insensitivity, the insulin being there, not responsive, not noticing the fact that there's too much glucose, cannot bind to it. Something is wrong, right? So the largest risk factor for type 2, they say 90% of the cases are type 2 cases. Largest risk factor is obesity, people who are obese, right? Obesity is a large risk factor. And we said they're not prone to ketosis because the body is not going to be breaking down the fat. It's the last resort for it. So type 2 person is less than likely to have ketones when their glucose is high, all right? Latent autoimmune, diabetes of adulthood. Initially, of course, type 2 diagnosis. And whenever we talk about autoimmune, always think antibodies that are produced that may be inducing or causing the diabetes, right? Now, type 2. Remember we said type 1 is common in the young and they're thin, right? They will get more cases. And type 2 used to be adult onset. That it used to be called adult onset, and they're calling them now type 2. So we're having more young people diagnosed with type 2 because of obesity. More young people that are obese. So it becomes big time healthcare issue, right? It's a challenge to healthcare, not just nursing, but healthcare, to deal with larger number of the youth being diagnosed with type 2.
Oh.
Yes.
But can you help us relate
Obesity.
obesity
Remember, somebody who's obese. Okay, we're going to talk about this another time that you will see. Somebody who's obese is, they're bigger, right? There's excess fat, right? Excess fat tissue. There's so many things going on with obesity. I'm going to show you in the next one. The next one, this one here, metabolic syndrome. So that diabetic person, right? It's about the waist circumference is too big, bigger than normal. Excess fat. We're eating too much, more than the body needs, more than the body can handle. As we grow older, things change. The body is not as effective. Remember, we're talking about gerontological effects. Things change. The body is not as effective. We can't run as fast as that young person anymore, right? So we can't lose all those fat we are piling up as quickly as we could have done if we were younger, right? So when we eat too much, when we have so much storage, high triglyceride levels, okay, high cholesterol levels, that's what you see with obesity. They tend to have high blood pressure. All these things are, really things that face, somebody who's obese. We're eating a lot more than the body can really do. We're eating a lot and not exercising as much, So that's metabolic syndrome. It's another condition that results into diabetes. So before, most patients we skip the other one. This one, gestational diabetes, pre-diabetes, and secondary diabetes. Different types, type 1 diabetes, type 2. Then other types of diabetes. Gestational, right? People develop diabetes during pregnancy because the body is stressed by all the work of pregnancy, the extra weight they have to carry, the extra food you have to eat to meet up, right? All those things. Then it's hormonal changes, hormones. This feedback I'm talking about is all about hormones. The hormones, it's cyclical. It has to balance. So with pregnancy, there's a pathway to the hormonal response. And it starts from the brain, it starts, the hypothalamus, right? And the message, they are chemicals. Hormones are chemicals produced in the body. So with pregnancy, they get the hormones of pregnancy, right? And there's stress associated with pregnancy. And not everybody, person's body, is ready to meet or cope with that stress. So a lot of people develop that.
You're really just saying that not everyone's body is coping with the pregnancy. Is that normal for everybody's body, or is just that person?
Well, remember, we're talking about disorders. So, and it's individualized. It's individualized, right? Somebody now may be pregnant, and pregnancy, it's all about hormones, right? For somebody to be pregnant, you have to have those hormones, right? Hormones with the menstrual cycle. So it's there. And then the changes, because to become pregnant, there has to be a high level of certain hormones, right? And a lower level, right, of others. And then if the body cannot meet with these changes and say, okay, now I have high level of this. Now there's pregnancy. Therefore, my pancreas should produce a lot more insulin to meet with whatever I have to eat for this pregnancy, or the weight that I have to gain because of the extra stuff. So it's a lot of processes that take place within the body with pregnancy. And it often results around what? 26 weeks of pregnancy. 26 weeks. It doesn't start from the beginning. For somebody who never had diabetes. So people who get gestational, they probably never had diabetes. Not everybody. Gestational is that person didn't have diabetes before, but during the course of the pregnancy, they developed that. Around 26 weeks of pregnancy.
Or if the person inherited from the family?
Well, there are different things. So it could be somebody whose family who has a genetic predisposition, but not every time. There are people who don't have anybody in their family that has diabetes. But the stress of pregnancy on the body now causes inability of the pancreas to meet with the need. It doesn't happen all the time. Somebody may have it, in a pregnancy, and in other pregnancies, nothing. Okay. I developed it with my, I don't know, one of my kids. What number? But the other ones didn't have it. Yeah, I know. I developed it with the fifth one. I have it very much, so don't worry about it.
What are the likeliness of after pregnancy that you develop,
Yes.
still have to be like develop
Diabetes. So
type
people
2.
who develop gestational, they are at a great risk for developing diabetes later in life.
Great.
Oh yeah, high risk. Yes. But you know what? If how many of us can really, we have this New Year resolution, we're gonna lose weight, right? And then by February we forget. we don't lose the weight. So the only way they don't develop it is if you really strictly modify your lifestyle. All right, you really have to. modify your lifestyle and really adhere to it. And we don't. We know that you are at risk for developing it later. You know, we're trying. After a while, it comes knocking. Comes knocking on the door. So that the sexual diabetic patient is at risk. So after the pregnancy, it goes away because the stress is gone. The stress is gone. They don't deal with it, you know. So they have to meet with the dietitian to know how to eat for that pregnancy and check their, monitor their blood glucose levels. They may need insulin, depending on how much glucose they have. They may need to take insulin during pregnancy. After the pregnancy, it goes away. They monitor it maybe the first year or a few months later. It will be gone. It will be gone for like 5 years, 6 years, 10 years, But they have to watch out. They need to modify, lose weight, control blood pressure, take good care of themselves. Exercise is great to incorporate into the lifestyle. And if they are able to lose weight and, have their, cholesterol level, blood pressure levels, everything in good check, they may not develop it. All right, just like any other person. Not only people who have gestational diabetes, any other person, as we grow older, things change. We are all at risk for developing it if we don't modify lifestyle. Okay, so then we have pre-diabetes. Pre-diabetes for patients who are in pre-diabetes stage. They have, the pancreas is working not enough, right? So problem, they still have elevated levels of glucose. But they have those other factors in the other slide I talked about, the metabolic syndrome. Okay, so how we diagnose, we're talking about glucose level between 70 to 120 normal, right? So in pre-diabetes, we're looking at somebody who may be having 126, 130, right? Maybe not up to 140, right? Greater than normal, right? So they are just in between. So you can't say that you cannot say diagnose them with diabetes because they don't meet that number. But they are not normal. They're not falling within the normal range. So they're in the middle, just before the diagnosis of diabetes. They may have hypertension. They may have, high cholesterol. They may have. So any of these, the metabolic syndrome that I talked to you about, this people have to, if they have at least 3 of these wrong, then they are diagnosed as being metabolic syndrome. And metabolic syndrome is almost like being at the fence. They are mostly those pre-diabetic patients. They are at the fence in the middle. They can be pushed over this way if they don't comply, adhere to the modified lifestyle. But if they do, they go back where they would not be diagnosed. All right? Yes.
Pre-diabetic people are the ones that they try to give them a nutrition pattern
Yes.
to follow.
Yes.
They change the diet. They'll be
Change
fine.
diet and exercise and right. If they adhere strictly to it, they may, like I said, they'll be at the fence and they won't go over.
What is elevated fasting plasma?
Yeah. Okay. Fasting glucose. Fasting glucose. Like before you eat, you check they draw blood and to check your glucose level. Elevated fasting glucose, right? You do your finger steak before eating. But they draw blood. They check it. Plasma level. So they draw blood. They send it to the lab, and they get a result. We're going to talk about that. How to diagnose. How to diagnose people. All right. So going back to this slide again, we have secondary diabetes. So some people may become diabetic just because they are on certain medications for other problems that they have. Right? So secondary to receiving certain medication, then they now start having abnormal glucose levels. People who are on prednisone, steroids, That's an example. Steroids, the dilantin. People who receive dilantin, some psych meds. There's one psych med. I can't remember the name. Huh? Some psych med. There's one psych med. I think Synthroid also. Synthroid, thyroid medication. So these people, they are at risk for developing diabetes because of these meds that they are on. So what they do when people are on these meds, they need dilantin for seizure, right? They need steroids for like autoimmune problems, so they have to have it. So they will now have a plan to monitor them like every 3 months, every 6 months, they draw blood and monitor them to see if they have developed it. All right, so they are at risk. They may not develop it, but it's something they have to, keep in check every 3 to 6 months. All right, that will be in their plan. Now, secondary diabetes, if somebody has motor vehicle accident, they're in trauma, and then maybe anything that damages their pancreas, right? So pancreas is the factory to produce insulin. If there's damage to the factory, then, somebody runs into the factory, they will not be able to produce, right? They will have temporary outage, right? So pancreatic trauma, or even cancer of the pancreas, right? And that destroys the tissues, so the beta cells will not be able to produce insulin anymore. So those things can lead to secondary diabetes. So secondary diabetes means, they didn't have those other, it wasn't because they became diabetic from what we have described about type 1, type 2, but they became diabetic because of additional problems, right? Okay. So we did talk about the metabolic syndrome. It has to be at least 3 of these to meet up with the metabolic syndrome. So anybody in metabolic syndrome will be at risk for that diagnosis of diabetes in no time.
Sorry, can you just tell us the difference between somebody that you say had an onset of diabetes and somebody?
So somebody with a type 1, like we said, type 1, they have his pancreas not producing it at all. So definitely they have type 1, definite diagnosis of diabetes. Type 2 person has some, but not enough. If we give them medication, then, they will be fine. They can, they wouldn't be having that overflow of glucose, right? So, and that's that. But somebody,
Onset.
with the
Somebody you say.
with metabolic, they're not diabetic.
No, I'm saying like onset, when you have
New
to
onset?
tell somebody that he's on onset that he's beginning to have diabetes.
Right. New onset diabetes.
Yeah.
Right.
So,
The new onset is that somebody who's older, 40 years old, never had diabetes. Now all of a sudden, see you tomorrow. Okay. So all of a sudden, the 40-year-old will now start having symptoms. Now start having elevated glucose level, more than this. Right. Start having symptoms of diabetes, like, voiding too much. They are so thirsty, we're going to talk about them.
thirsty.
So thirsty, you feel like they have to drink a lot. They feel like they're so thirsty all the
It's not
time,
like
right?
the urea will be colored.
Not the color, no. Just,
Yes.
well, of course there is smell.
Frequency.
Oh, yeah, it could, well, of course, it's high sugar, it may be very concentrated. Yeah, but it's
I missed what you were saying for
the urine.
for which type isn't that people end up really thirsty?
Both types. Just when the glucose is too high.
Oh, okay.
Yes, greater than 300 or something. Hyperglycemia, which we will talk about. Yeah. So they start having those things. That's new onset. Remember I said, a lot of times we're saying that over 6 million people don't know that they have it, but they have it. they're walking around until all of a sudden they have these symptoms that they can't deal with anymore. You know, like if they've been going to the bathroom several times, voiding a lot, they said, my God, I can't get any sleep because I've been going to the bathroom at night. Not about the color. Not about the color. You know, or maybe I've been so nasty, what's going on with me? It usually will go along with, the feelings of pins and needles. That's what high glucose does. You know, pins and needles, they have nerve pain, nerve destruction because of too much glucose. It does damage to the blood vessels and to the nerves. So in the long run, they have problems. So that's way, the new onset, they now said, oh my God, let me go to my doctor, tell my doctor what's been going on. And now they check and find out, oh, it might be really high, right? Okay. So signs and symptoms, typical signs and symptoms, the 3 P's. You can remember it as 3 P's: polyuria, polydipsia, polyphagia, right? So, fatigue, blood vision. Blood vision is a big one. I remember I said complications. These complications, they start from the beginning. They start even before the person knows that they are diabetic. It starts happening over time. They can't, it worsens. Infection prone. The glucose, right? The blood has so much glucose, infection organisms can feed on it. So they are prone to infection, and they can easily get a bruise, and once they get a bruise, it wouldn't heal. It wouldn't heal. Organisms can come there because they're too sweet.
The blood don't clot.
The blood is too sweet, right? It's a good venue for organisms to grow and thrive, so it doesn't heal. That's a problem with them, right? Abdominal pain. These are typical for high glucose levels. Ketosis, right? Acidosis, and that's typical for a type 1. But these are generally for any diabetic patient. These are symptoms they should watch out for. When they start feeling any of these symptoms, they should, call their healthcare person.
Does the symptoms go away as long as you start feeling it?
Huh?
Does the symptoms go away as long as you start feeling it?
Does it go away
Yes.
when you start treating?
No. If you doesn't treat it, does it go away? Like you said,
It won't go away.
Okay.
You would not go away. That's the thing. That glucose will be in the bloodstream. It won't go away. You got to remember we said you must have this to drive it into the cells. That's how the body is made.
Now we're talking about the symptoms.
Type 1.
No. Anybody. Remember, we all do need it. The pancreas is producing insulin for type 2. That's why they don't have to go shopping. But there's a time which we'll talk about when they need to go shopping for insulin. Alright? So these are the typical signs and symptoms. To diagnose somebody as having diabetes, how do we diagnose somebody? 3 ways. These 3 things here. 3 different ways to diagnose. The doctor, once you go and you're having symptoms and you say, oh my God, I don't know what's going on. And the doctor said, okay, did you eat today? You said, no, I didn't eat. Okay, let me check your sugar. They, prick your finger, they draw some blood, fasting plasma glucose. When you didn't eat and they draw the blood, you didn't eat for at least 8 hours, and then they draw the blood, it's fasting plasma glucose. They send it to the lab, they get a result. They're looking for the numbers. Remember, I'm talking about this, right? So if we get a number greater than or equal to 126, ooh, we said there might be a problem here. There might be a problem, right? So now, they don't diagnose just because of the one result, no. Because of the fasting only, no. Now the doctor will say, okay, come back at the end of the week. Come back, at the end of the month. Let me check again. They do casual plasma glucose. Casual, you ate your breakfast, you came to the doctor's office. Let me just draw your blood and see what we get. Remember, I said negative feedback mechanism. Normally, the pancreas should know that this person just ate. They just had the end product glucose. I need to produce insulin to address it. That's it. Casual plasma glucose, 2 hours after you've had food, you should not be having abnormal level. It should already take care of it and drive them all into the cell. so that when you check their blood, it should be okay. It shouldn't be greater than 200 for casual. So if somebody has eaten, we expect glucose to be produced. So we're not using this number, right? Because fasting is that you didn't eat. You never have food for 8 hours. Okay, so there's no reason why your glucose should be high, right? So that means when it is higher than 120, that's a problem. 126. And then casual, you ate. Yes, I expect glucose to be produced, but I don't want this glucose to be greater than 200 because I know you ate. So before the next meal, it should really normalize. So, but they look at the casual and they get greater than 200. That's a problem, right? It shouldn't be. It should be at least 180, up to 180. Now, that's two. Fasting, casual. The third one, they do this too. They want to check glucose tolerance test. Remember the one that people even go for 26 weeks of pregnancy? That's glucose tolerance test. They say, come on, let's see. They now come, you'll be fasting, you wouldn't eat anything. So you come in, they draw blood twice. First, the baseline. The first draw, now they have that drink. You know how the drink is how much amount of glucose in it. So it's a measured amount of glucose. They know how much glucose they're giving you. So they expect it to be taken care of if your system is working well. So you now take the glucose drink, you stay there, you don't go home. For the next 2 hours after you've swallowed that drink. Remember they took a baseline, they did the blood work, they have a baseline to compare with. Then they give it the drink. 2 hours later, they draw blood again. Now they're looking at it, wow, how much are we getting? Greater than 200? So now, all the three different ways, they put it together and they said, this is not a coincidence anymore. There's a problem. So that person can now be diagnosed as being diabetic, type 1 or type 2. All right, so this is the typical way that they diagnose. Not based on one result only, but based on these three. All right, okay. Additional tests. Now, glycohemoglobin, yes.
But those three tests, are there also the same tests that you can do for gestational and for pregnant?
Well, it's mostly that. It's mostly 26 weeks they do the glucose tolerance test. But of course, they will already have labs for them that can maybe point you towards that. Because they draw blood every time with pregnancy. And then they know that, oh, we're seeing that your glucose has been a little elevated, right? So now they come in for the glucose tolerance test at 26 weeks, and then they check it and then they confirm that they have gestational. Because they didn't have it before pregnancy, then they say they have gestational, right? So additional tests. Remember I said those three, right? The first three that we just talked about. Now, to confirm, they need these tests. Glycohemoglobin. It's also called hemoglobin A1C. Hemoglobin A1C. It's also called glycosylated hemoglobin. Glycohemoglobin, glycosylated hemoglobin. Hemoglobin A1C. Now, what happens is, it says hemoglobin, right? You know the glucose molecules that are floating in our bloodstream, right? Remember the blood is hemoglobin, right? So the glucose molecules attach to the hemoglobin and they're stuck together for life. The hemoglobin has a lifespan of 120 days. Each time we produce, the blood produces all the time, replenishes itself, right? So that hemoglobin, once it's produced, it starts circulating through the body. After about 120 days, that one will die and more blood cells will be produced. So from the time you eat that food and you get your glucose and you have problem with your metabolism and the glucose is circulating, it gets attached to hemoglobin molecules. And they're marked for life. Just think about it that way. They're marked for life. For the next 120 days, those glucose molecules are attached. So they draw the blood to check hemoglobin A1C. That shows for the past 3 months how much glucose you've had on your body for the past 3 months. So when they get an elevated level, it goes to confirm the 3 tests that we did in the previous slide. So to diagnose somebody is not with hemoglobin A1C, but it confirms the diagnosis. You understand?
Sorry, what's the elevated level for that diagnosis?
Right here, this is the normal level.
46.
4 to 6% percentage.
Anything above 6.
Anything above 6%. So when they're looking at it, people get 7%, 10%, 14%. And you know what? The higher the number, the more problems, the more complication. And this, remember, we're saying for 3 months, that glucose is floating in your bloodstream. That's 3 months of damage. Doesn't play. That's why a lot of diabetics have problems. All right. So they look at lipid levels. Okay. They look at serum creatinine, urine microalbumin, because the kidney is involved too. Remember they're peeing so much. Okay. There are blood vessels that supply the kidney. Remember the damage, the complications or damage to blood vessels. The blood vessels that supply the whole body. The big blood vessels that supply the heart, the brain, the small blood vessels, tiny vessels, that supply the kidney. It starts showing in the function of the kidney. So they're looking at the kidney function. Are there any impairment? Is it spilling over to the kidney now? And it's affecting the kidney. Okay. So they use all those in addition. These are additional things to confirm the diagnosis. All right. So how do we prevent? Remember we said majority of the cases is because of obesity. So we need people to lose 5 to 7% of their body weight. That increase waist circumference. They need to incorporate exercise. We need to incorporate exercise in our lifestyle. At least 30 minutes for 5 days a week. We are really saying that if you can only do at least 30 minutes a day, that it really will help a lot, right? We must do that. Those people that are pre-diabetics, those people with that diagnosis of gestational diabetes who are at risk for developing it later in life, if they do these things, it may prevent the diagnosis. Reducing fat and calories, what we consume, modifying diet, right? So these are the ways to help to prevent. So the goal of treatment for the person who has the diagnosis of diabetes. This is not a normal person. This is somebody who's diabetic. So you expect that they will not be 70. Expect that they will not be 120. Right? So, but if they fall within 90 to 130, fast, preprandial means before meal. Pre-meal. Preprandial before meal, right? Before eating. So it's almost like fasting. So they want this glucose to be 90 to 130. If it falls within that, that's good control. That's the goal. Doesn't mean that's always like that, but that's the goal. So peak postprandial. Remember the 2 hours after eating, the casual after eating. So they expect less than 180. And for a diabetic patient, this is not a normal person now. Somebody who's diabetic, diabetic, they want the post meal 2 hours later. If it's less than 180, it's good control. They like that, right? Remember, we're saying we diagnose when it's 200 and more, right? So the goal is to keep it at less than 180. Good blood pressure control. Good blood pressure control. They already have complications and problems with their blood vessels. Now, if they have high blood pressure in addition, it's more and more complications for them. So they need good control, all right? Glycohemoglobin of less than 7%. We said normal is 4 to 6%, right? So less than 7, they can manage. This is for a diabetic patient. Therapeutic interventions, we have to look at nutrition for a diabetic patient. We have to look at exercise pattern, medications, monitoring, keeping, monitoring of the glucose, and education. That's the way to address, right, the diabetic patient with all the problems that they're, having. They need to understand what to do in terms of nutrition. okay? Because you're having problems with glucose utilization. Therefore, you can't eat just anything you want. I've been thinking about it and I said, wow, that's like sentencing. It's like being sentenced, right? You cannot just do what you like. You see, before in pre-diabetes, you have all the leisure, right, to do what you like, and then you didn't adhere to it, right? So now you are sentenced, you must control what you eat. So they need to know about medical nutrition. They need to know what they need to incorporate the exercise. They said at least 30 minutes a day, right? Medication, right? Education is a great thing with diabetic patients, right? So when we talk about medical nutrition therapy, about American Diabetes Association exchange list, there are exchange lists. The exchange list means, there are specific amount of food. So if you want to eat, let's say white toast or a slice of wheat bread, whatever, it has a certain amount of calories with it, right? So they give these equivalent. So when they make, or you go to a dietitian and a nutritionist for a diabetic patient, then they tell them there's certain how much calories they need to maintain good number. So sometimes they have 1800 calorie diet. You see when your patients have 1800 calorie diet, sometimes they have 1600 calorie diet. Sometimes they have 1000 calorie diet, depending on their need. So it's tailored to the person's need, right? And then there's a list of food where they can pick what to eat that can guide them so that you won't, some of us Africans, we go to a party, right? We fill our plates. We sit down, we eat it all. You can't do that anymore. You can only have small portions. Okay, you can only have small portions, all right?
That's everybody.
Yeah, everybody, but I know about us. I can talk what I know. So carbohydrate counting. Remember, we talk about carbohydrate when we eat carbohydrate, and that's how much amount of glucose that it yields. So you have to know the specific food and how much carbohydrate that it contains, so that you know how much you can eat of that food. Glycemic index, in terms of breakdown of the food. Some food, when you eat them, they take a little longer for the digestion to complete. Some of them digest really fast. So, they're using glycemic index of certain food to decide what to pick, to decide the choice. Then, of course, we think about the cultural aspects, right? Cultural aspects, what kind of food do we eat? Our people, we love yam. You know the yam? African yam is really high calorie food. Right? Pounded yam, the rice, rice is staple food for so many people. So it's really high. We need to be educated. So when you know your patients and you know about their cultural food that they eat, now your goal is to teach them that that yam that you eat, you can't fill your plate with a plate of yam. I miss the yam, the yam is so good. I can't just eat it the way I like to eat, The farina that we eat, balls, we make these balls, they're so high. But, we have to be educated about what to eat. So we love the food, but this is how much portion we should be using, right? So we have to always remember cultural aspect when we are teaching our patients, right? That you can't eat all that, this is how much you need to eat. Principles of medical nutrition therapy, it's about low fat, right? You don't have to fry your food all the time, right? You can just bake it instead of frying, right? Limit sodium, right? We want the blood pressure to be under control. So they need to know that they need to limit sodium intake, all right? Limit simple sugars, those things that can, yield glucose that the body, that will be there readily available, and use more complex carbohydrates that it takes a little longer to produce the glucose, right? So, and consistency is the most important thing for a diabetic patient. Being consistent. The worst thing that can happen to them is the fluctuations in the glucose level. The fluctuations, it does more damage than anything. So consistency, that means if you're exercising every morning, be consistent. You're doing 30 minutes a day. try and be consistent. If you're eating breakfast at a certain time and this amount of food, not you today you fill up your plate, tomorrow you eat that little thing. No, consistency, maintaining good level. It's better to decrease complications. Exercising lowers glucose, right? When we exercise, we burn up, right? And also lipids, it decreases lipids, right? We said we have to look at lipid profile, right? With the metabolic syndrome, looking at the lipid profile. Best done regularly. If you're doing exercise, be regular with that routine, all right? But some people have a lot of problems going on with them. They have other issues. They may have problems with their hearts, congestive heart failure, that they can't do so much exercise. So you need to really go to the doctor, make sure it's appropriate. Whatever exercise you're doing, that your body can deal with that. Avoid exercising during acute time. There's acute time when they have those abnormal levels where it is too high or too low, which we're going to talk about. So avoid, because stress induces cortisol. Cortisol also, causes high glucose. Remember I said cortisol, steroids, people are on prednisone, and that's a secondary thing that can lead to high glucose levels. So when they're already during acute time, when it's already high, when the glucose is already like 400, that's not the time to exercise. Because once you exercise, it's a lot of stress on the body, and the body will really deal with, with the negative feedback mechanism, will produce cortisol. And that will even complicate the problem, right? So during acute time, when they are sick, that's not the time to start exercising, because it will be elevated more. Carry fast sugar. They need to carry fast sugar with them when they're exercising, because it will drop, their glucose may drop, so they need that quick fast sugar, right? So they don't have problems of low, right? Hypoglycemia. Snacks. Yes. So medication, insulin, right? Insulin, we said type 1 needs it, must have it. The type 2, we'll get to the point where they may need it. They do, some type 2 patients do have it, right? But it's not mandatory. They can have it in addition to their pill. Only because they're giving them the pill, and the pill is not addressing it effectively. So they just give them, they call it a sliding scale based on how much glucose, right? So you then have to take let's say, glucofag this morning, and the doctor will say, when you check your glucose, right, and if you get 200, if you get anything less than 200, it's okay. You don't have to take insulin. We're fine. Deal with it, right? But there may be people, each time they check their sugar, they may be like 260. They're higher than 200. So the doctor may give them, a sliding scale just to take care of that excess amount. Okay? So it's almost like somebody who has pain, and they call it breakthrough. It's almost like a breakthrough just for the excess. So that's the time they order insulin for a type 2 person. When they've been managing it with the pills, and they seem to be having higher and higher number, even with the pills, then the doctor will say, okay, because they know, there's damage that is being done. Okay. I have it. I'll give it to you.
Everybody?
Yes.
Oh, okay.
Yes. Everybody's here? Okay. So, and then we have oral hypoglycemics, right? And those pills. Remember I said they get those pills because of whatever their need is, whatever is going on with their pancreas. I have it.
You do?
I have it. I'll find it. Okay?
Chris, can I put down like the last 5 minutes? What time do you finish today?
I haven't even taken a break. Hold on. Do you guys want to take a break?
Yes.
Yes.